Curiously, this is a session on diagnosis, management, and treatment of Pompe disease. The first speaker will not be here, but his presentation will be here. So that's Dr. John Bach, who's unable to come. And he is talking about respiratory management of Pompe syndrome.
Okay, everyone hear me? I am there in spirit. I would have been there, but I have a health problem, and I'm very sorry that I'm not with you. I would have loved to have seen the house family again and my dear friend, Dr. Kishnani, but I'm sorry that I cannot be there with you. But you hear my voice, and basically I am there, okay? So now I'm going to say next to advance the images, and I'd like to go to the fourth image. So next. Pompe disease goes through all the different classifications of neuromuscular disease. So in other words, what I consider neuromuscular disease type 1 is onset at birth, where the infant does never have the ability to sit. Type 2 is when an infant can sit but can never stand or walk. Type 3, neuromuscular disease or Pompe's disease, can be often confused with limb-girdle muscular dystrophy because the child can walk for a period of time and maybe even into adulthood, but eventually loses that ability. In type 4, it's adolescent or early adult onset, and in type 5 is later adult onset, which is really most common in Pompe's disease. Now, in each of these classifications, you have to be aware of different risks for respiratory management. So, for example, in the most severe type, the children become continuously respirator dependent before 5 months of age. However, they don't need tracheostomy tubes. They can be managed non-invasively. In the type 2 situation where a child can actually sit independently, they usually can breathe all right. But half of these children have paradoxical breathing, just like the type 1 children. So what I mean by that is that when the diaphragm goes down and the stomach goes out, the chest sinks in. That causes what we call a pectus excavatum, and the lungs do not grow. So any child with paradoxical breathing must be on nighttime ventilatory support. Otherwise, their lungs will not grow. So that's only a consideration generally for type 1 and type 2 Pompe's disease. And I'll talk a little bit more about that later on because that's very important. But I don't know if any of you have children with the infantile Pompe's disease. Actually, for neuromuscular conditions, Pompe is actually kind of worse because what these children really die from is cardiac involvement rather than respiratory, because respiratory can be prevented by using non-invasive ventilatory support, but we don't have the replacement therapy doesn't completely, by any means, prevent the effect on cardiomyopathy, as I'm sure you will hear about from other physicians. In the adult, in the later varieties, though, like in type 3 and type 4, the real problem is that the cough is weak, that the ability to generate cough flows weaken, and when patients get respiratory tract infections like bronchitis or the flu, they have a higher risk of developing pneumonia because they don't clear the airways secretions very well. Now, and we have something called mechanical insufflation-exsufflation, the so-called cough assist, which can prevent pneumonia for most of the time for such people with weak cough mechanism. Next. So, as I mentioned, the Pompe classification goes through all 4 groups. In fact, most neuromuscular diseases, you have type 1, 2, 3, and 4. Congenital myopathies, congenital muscular dystrophies, spinal muscular atrophy. You can have children that are type 1 and never have the ability to sit. You can have adult onset as well. But for all of these cases, 4 things should be checked every time you see a physician. That is your carbon dioxide level, your oxygen saturation, spirometry, and cough flows. Excuse me, boy. Now, and next, this is a child with Pompe who's floppy at birth. And you see that he has no muscle tone and has an NG tube. This could be anybody with neuromuscular disease type 1. Next. Now, this is a child with spinal muscular atrophy. Now, generally, with the severe infantile Pompe disease, the children are dead by 1 or 2 years of age because of cardiac failure. However, in other neuromuscular diseases, type 1, the conditions don't necessarily affect the heart. So you can see what happens when a child is not placed on nighttime ventilation. This child is about to die. His photo was actually used in a book by a British physician on managing neuromuscular disease, and it's quite frankly disgraceful because he demonstrates exactly not what to do for the child. This child's chest is very thin and funnel-shaped, and his lungs will not grow and he will die. Now, next, you see children with very severe neuromuscular disease type 1. Both of these brothers have been continuously respirator supported since 4 months of age. 20 years ago, I told their parents that they would be dead within 1 year if they didn't get a tracheostomy tube. But the parents refused it, and they forced me to do what I do for other patients. And next, at the age of 20, these children are still alive. They have 0 milliliters of vital capacity. That is, they cannot move a single milliliter of air. Now, if you have any patients who have been to physicians, and the physicians check your vital capacity, and, well, today you can breathe 2,000 milliliters of air, that's maybe 50%, and next time 1,000, that's 25%, and then they say, boy, you're getting into trouble. You're going to die because you can't breathe. Well, that's nonsense. We have patients with 0 milliliters of vital capacity for over 60 years, and no respiratory complications whatsoever, and no tracheostomy tubes. So in this photo, you see these boys are now 20 and 18 years old, but they're not the only ones. Next, this little boy with neuromuscular disease type 1 has been using a ventilator since he was 1 year old. Now look at how thin his chest is. He's starting to use the ventilator, nasal ventilation at night, not BiPAP, by the way. Next, now he's 22 years old. 24-hour non-invasive ventilatory support. He'll never have a tracheostomy tube any more than the other boys, even though the vital capacity can be 0 milliliters. Next. So again, it's really all children who have paradoxical breathing need to be on nighttime ventilatory support, not BiPAP. And I'll explain why not BiPAP soon. So what is non-invasive ventilatory support? Next. Well, it's nasal ventilation, just like you would do for a BiPAP unit, but there must be no holes in the interface. So in other words, that nose piece cannot leak. There must be a seal at the nose, and then it's connected into tubing that has an exhalation valve. We call that an active ventilator circuit. Now, BiPAP is delivered with a passive ventilator circuit. And so there are holes in the interface and in the tubing so that when the patient exhales, the air that they exhale goes out those holes. That's how BiPAP is set up. The problem with BiPAP is you cannot turn off the expiratory pressure. And the expiratory pressure is sort of like, it stops you from exhaling. It's something that is completely unnecessary. It's actually counterproductive. It increases the pressure in the chest for nothing, for no reason. And you have to increase the inspiratory pressure by the amount of the expiratory pressure to give the person a deeper breath. So there is no reason for BiPAP in anybody with Pompe's disease. Now, can you use BiPAP at adequate settings to give deep breaths? Yes. But frankly, the very few physicians that understand this would not be prescribing BiPAP if they do understand it. So most of the time when people are on BiPAP, they're using it at grossly inadequate settings to rest their muscles overnight so that they're stronger during the daytime and to expand their lungs so that their lungs remain healthy. So next, we see that little boy Nicky again with his vent. And now this is a type 2 child. And again, she can breathe fine, but if she gets a cold, I think I said next there. It's a little girl sitting in a wheelchair. Next, these are type 3 neuromuscular disease. They're able to walk, but they'll stop walking in a couple of years, and they'll also have problems only when they get respiratory infections because their coughing apparatus is weak. Let me tell you right now, you don't need a lot of vital capacity or ability to breathe to ventilate your lungs. So in other words, for an adult, normally we are able to take breaths up to 5,000 milliliters. But 1,000 is generally more than enough to maintain normal carbon dioxide levels in the blood, to maintain normal lung ventilation. However, you need 2,500 milliliters of vital capacity to cough effectively. So, in other words, to cough, you need to take a deep breath, then you need to generate pressure with your abdominal muscles, and then you need to hold that pressure with your throat, what we call the bulbar muscles, or the glottis. You need all three for an effective cough, whereas you only need a liter of volume or so for an effective breath. So this is why these children, and adults for that matter, with the weak abdominal muscles and low cough flows, develop pneumonia. Next slide, please. So 4 things need to be measured every time anybody with Pompe disease goes to a clinic or a physician. One is carbon dioxide levels. Now, you never need an arterial blood gas. The doctors, if they want to stick you for an arterial blood gas, it's only because you can charge for that and get paid for it. It's completely unnecessary. End-tidal carbon dioxide is in many ways more accurate than a blood gas because 30% of the time when they stick your artery, you hyperventilate from the pain and artificially decrease your carbon dioxide levels. Again, there are 2 important gases in the blood, carbon dioxide and oxygen. As we breathe, we maintain our oxygen level and we exhale carbon dioxide. If we don't ventilate our lungs adequately, the carbon dioxide goes up and the oxygen can go down. So next, besides the end-tidal carbon dioxide, which is totally painless, and it samples air at the nose when you exhale, you have an oximeter. Now this ancient oximeter, everybody with Pompe, with weak cough, needs to have an oximeter at home. And the oximeters now can be purchased over the internet for under $18. So there's no excuse not to have an oximeter. Next, this is a $15 peak flow meter, which is important for measuring cough flows. And next, this is a spirometer. Now, it's not a digital spirometer because digital spirometers really cannot measure the things that we need to measure for you. Besides vital capacity, we need to measure the ability to air stack, which I will get into, and you cannot do that with digital spirometers. Next. So there's 3 aspects to managing or preventing respiratory complications of Pompe's disease. I like to separate it into pediatric and adult. Now, I take care of children and adults, but most physicians take care of one or the other, and then patients have to switch teams when they're 18 years old. That's most unfortunate, I think, but that's the way it is in the United States. So there's children and adults, and then there's the ability to extubate patients who are unweanable from ventilatory support. So in other words, if somebody gets a respiratory infection and is hospitalized, and they're in critical care, an intensive care unit for a period of time, maybe days or weeks, they can get so weak that they're too weak to breathe. And then the physicians say, oh, we cannot take this tube out of your throat because you're too weak to breathe, so we have to put a tube in your neck. That's a tracheostomy tube. Well, I'll tell you right now, nobody ever needs a tracheostomy tube because they are too weak to breathe. You can extubate a patient to nasal, non-invasive ventilatory support, mouthpiece ventilatory support, and you can remove their secretions by using mechanical insufflation, exsufflation, assisted coughing methods. So I strongly suggest to all of my patients that if they go to a local hospital because of a pneumonia and they're intubated and 10 doctors are telling them they have to get a trach tube, just don't consent to it. They can't do it if you don't approve, if you don't agree, and then they'll have to call me, and you can be extubated the way we do it or be transferred to us. But no one with Pompe's disease, certainly no adolescent or adult, should ever have a trach tube. And if any of you do, we'd be happy to evaluate you to remove it. If the tube hasn't caused so much damage that your trachea has basically been destroyed by it, we can remove it safely, and you will never need a tracheostomy tube again. But that's the next category, decannulation to non-invasive ventilatory support. And that's what I'm talking about. It's easier to extubate, that is to remove the endotracheal tube of acutely ill people who are too weak to breathe, and extubate them to non-invasive support rather than trach them. It's easier to do that than it is to remove the tracheostomy tube once you already have it. But we have a 100% success rate at doing both, essentially, for Pompe's disease and most other neuromuscular conditions. Next, I want to show you a mouthpiece ventilation. Now, you can have the mouthpiece in the mouth. Next. And this is a microphone holder that holds the mouthpiece near the mouth so the patient can grab it and get a deep breath. Next. Excuse me. And next. There's just different people using mouthpiece ventilation. And next. This is my number 27 image here. And this is a woman who's been on mouthpiece ventilation for 61 years. She had polio in 1954, and she has been continuously respirator dependent for 61 years. Next, another lady, the same story. She's over 70 years old now. 24-hour non-invasive ventilation. Excuse me. Yeah, can you get me some water, please? This is a little unusual, even for me here. Excuse me. I got some water. Next image. Now, we have patients who can walk and have good strength of all their muscles except their breathing muscles. I have yet to see this in Pompe's disease, but it is possible that it could happen. And next, there's another patient in that category. Next. So, why is this misunderstood by physicians? Again, I apologize. And I'm getting a little bit of water here. Well, you see, physicians are taught that basically pulmonologists manage the lungs. And when the lungs are diseased, like mine for the moment here, normally people have a failure of oxygenation and they need oxygen. And pulmonologists are not programmed to think about muscles. So if a patient is too weak to breathe, their lungs are normal, but they have a failure of ventilation. But the pulmonologists don't think in those terms, so they have a tendency to give the patients oxygen and bronchodilators anyway, as though they had lung disease. But this is the worst thing you can do, because both actually make the neuromuscular conditions worse. Both the oxygen and bronchodilators can be harmful for patients with neuromuscular disease. Next. Now, this image should say most common errors. So misinterpretation of symptoms is one of them. Typically, people with Pompe's disease, when their muscles get weak, when they lie down, they get short of breath. And sometimes they cannot lie flat on their backs because they are short of breath. Now, the treatment for that is nighttime ventilation. It's not sleeping with 7 pillows or getting oxygen or being sent for a polysomnogram to sleep, what they call sleep-disordered breathing. So what do I mean by that? If you have fatigue, morning headaches, daytime drowsiness, maybe some difficulty concentrating, depression, loss of appetite, these are more severe symptoms of carbon dioxide retention. Very typically, pulmonologists and neurologists send patients for polysomnograms. Well, the polysomnogram is programmed to interpret every problem as being due to central or obstructive apneas. That is, the brain not telling you to breathe or the throat being obstructed. This is like blaming the brain and the throat for what the diaphragm can't do. The polysomnogram was never programmed to interpret the problem as being from muscle weakness. So as a result, the patients are treated improperly with oxygen and CPAP. and their CO2 will just get worse. In fact, usually with polysomnograms, they don't even monitor the CO2. So what we do is we can monitor CO2 and oxygen saturation, and that's much more effective than a $6,000 polysomnogram. Now, the other thing is they tend to send you for pulmonary function testing, PFTs. The PFTs are also designed for people with lung disease. You get forced expiratory volumes, looking for airway obstruction, plethysmography, looking for obstructive apneas. You get the nasal thermistor, looking for hypopneas and so on. But, no, I'm sorry, that's on the sonogram. The pulmonary function testing is nevertheless looking at diffusion to see if your lungs are healthy. None of this is important for people with Pompe disease unless you've been smoking for 40 years and have destroyed your lungs for that reason. And you have both a combination of lung disease and weak muscles. So that's why I'm telling you that the four things that need to be followed are the end-tidal carbon dioxide, the oxygen saturation, the spirometry, and the cough flows. Pulmonary function testing is a waste of time and money for people with Pompe's disease unless you have lung disease too. Failure to monitor sleep, well, as I mentioned, the polysomnogram is inappropriate. But if I have a question about whether my patient has symptoms or not, I will order a sleep oxygen saturation and CO2 monitoring. And if the CO2 goes up, then I will recommend a trial of nighttime nasal ventilation. There's an over-reliance on arterial blood gases. As I mentioned, you never need arterial blood gases. Even for my patients who are acutely ill, I don't get arterial blood gases because of the non-invasive ways to measure carbon dioxide and oxygen. And you see, when you have lung disease, the end-tidal carbon dioxide is not accurate. But in people with Pompe's disease or anybody with neuromuscular disease, the end-tidal CO2 is quite accurate. So you don't need painful arterial blood gases. Likewise, nobody with Pompe's disease, even infants with severe Pompe, ever really need a tracheostomy tube. Certainly no adults or adolescents ever need a trach tube. And I encourage you, if you have one, even if you're 24-hour vent dependent through it, you'd be better off without it, in my opinion. Because 4 out of 5 people eventually die from complications of the tube itself. Now, also, there's an over-reliance on airway suctioning. Even if you suction through a tracheostomy tube, 95% of the time you don't get the left airways because the catheter always goes into the right, almost always. So that's why most pneumonias are in the left lung. Suctioning into the airways like that is almost never necessary, probably is never necessary, because there's a non-invasive way of suctioning the airways that doesn't pick left over right or right over left, and it's called mechanical insufflation exsufflation, which I'll talk to you about. And don't even think about oxygen therapy at home unless you want to die, because the oxygen will turn off your breathing, and will make the oximeter useless as a gauge of ventilation, airway clearance, and lungs, health of the lungs.
Dr. Bach,
Yes.
This is Dr. Paul Plotz. I'm monitoring the session.
Yes.
This terrific talk is running a little bit over.
Oh,
and I would like to ask that you provide to us a good reference which summarizes what you have said. I think it's very important. I regret to pressure you about time, but would you send us something that we can disseminate to our physicians and patients? Absolutely.
Well, first of all, I have 1 hour, and I've only spoken a half hour so far, right?
No, not right. But Arnold, would you, or Tiffany, clarify?
No, that's a mistake.
We have 20 minutes.
You don't have 1 hour.
Half hour?
No, you have 5 minutes more.
5 minutes? You mean you wanted me to go to San Antonio for a 5-minute talk?
No,
5 minutes more.
more. You already did the 6.
Okay, I'll tell you what. First of all, as far as the references are concerned, no problem. I'll send a general reference, and I'll also send several articles on how we extubate and decannulate unweanable people.
That would be terrific. Yes.
So you'll have those references. The other thing I want to tell you before I forget is that right now I'm in the process of preparing a website on non-invasive ventilation. And when that website, I expect to have it up before the end of the year, I'm going to put outcomes of all of our diseases by humane non-invasive management and compare our outcomes to conventional management, which is simply letting people go into respiratory failure and then tracheing them. So if you look for my name in a few months, you should be able to find the website, and that website will have a tremendous amount of information on it about all of this material. But if somebody sends me an email, I'll send you a general reference on all of this, and also, as I mentioned, how to extubate and decannulate unweanable people so that nobody ever really needs a trach tube with Pompe disease.
That's terrific. We will send you such an email, and we look forward to getting those. I think we all need them. All the patients and the physicians need this. Thanks so much for talking. Really.
That's fine. So, any other questions? Excuse me.
What's your email address?
The BACHJR at NJMS. That's for New Jersey Medical School.
We have it actually here,
right.
So we'll disseminate it to the audience.
Right. Okay. So send me an email soon, and I can send you those papers.
Thanks a million.
Okay, you're very welcome. Okay, so I'll say goodbye.
Yes.
All right, bye-bye.
Before we have the next speaker, I wanted to say that we have a representative from Respironics here in the Rumba room through lunch. What? Respironics, isn't that what I said? Oh, well.
The representative from Respironics is in the Rumba room right off the area where we had breakfast and we'll have lunch. And he's got a trilogy, a cough assist machine, and some different masks so everybody can see them, see kind of what some of the items Dr. Bach was talking about.
Thanks. We'll now move on to the diagnosis and genetic counseling in pump by Dr. Deeksha Bali and Stephanie Austin from Duke.
Yes. Good morning, everyone, and thank you very much for giving me an opportunity to come and talk here. And I am going to talk to you briefly, very briefly, within 20 minutes, two of us, about how do we go about diagnosis of Pompe disease. And Stephanie is going to take over about the genetic counseling issues associated with Pompe disease. So these are our brief disclosures that we have grant funding and honorary or travel funding from different agencies. So odyssey of diagnosing Pompe disease, what goes on? So clinical suspicion is still the primary cause of starting the diagnostic odyssey for Pompe disease. And as you know, all know very well that symptoms in infantile Pompe versus late onset Pompe, they are very different, and the time which Dr. Kishnani and Dr. Kimonos talked about varies between different types of Pompe diseases, but it still starts from the clinical suspicion at your physician's office. And then there needs to be a proof of enzyme deficiency, which starts from the biochemical diagnosis using any of the enzyme activity assays. And if you find a deficiency in enzyme, yes, you have a diagnosis. And then any enzyme deficiency has to be proven with the molecular confirmation of two pathogenic mutations. Yes, if you have two pathogenic mutations through gene sequencing, you are good, you have enzyme deficiency, you have two pathogenic mutations, you have clinical suspicion, you have a diagnosis. But as we have learned in the past many years, there are many, many novel mutations, and there are variants, we call them in technical words as variants of unknown significance. That is that we don't know whether they are disease causing or they are not. And then we do have to, as Dr. Rioser said and Dr. Kimonos mentioned, we do have to resort to muscle biopsy in order to aid in the diagnosis or put a confirmatory diagnosis. And where we can do muscle biopsies, you can look at histology, you can do enzymology, or easier way of skin biopsy, which is not invasive or less invasive. And in late onset Pompe cases specifically, you do have to go to these cases, and it's not bad, it really helps. And for future therapies, this is the source of material which could be used to try different therapies and do research. And besides all those, there are the routine laboratory tests which everybody orders, EKG, chest x-rays, echocardiogram, more so in infantile cases, is helpful in aiding the diagnosis. And then pulmonary function tests, as we just heard, and CK and LFTs, they can aid in the diagnosis, but they are not confirmatory or diagnostic for Pompe by themselves. So looking at each one of them individually now, muscle biopsy. In histopathology, what you see in muscle biopsy, which has been nicely preserved and is handled properly, there are glycogen-filled vacuoles in the muscle fibers. And these vacuoles are more prominent in infantile form of Pompe disease as compared to the later onset forms, or it actually may be absent in some of the adult onset forms. And these materials stored in these vacuoles is usually, of course, glycogen, and it is PAS positive, it is diastase sensitive, it gets digested with diastase, and it stains very intensely with acid phosphatase. And I'm not going to talk much about it. This is Dr. Nina Rabin's expertise, and I'm going to stay quiet. And the glycogen which you see in these muscle fibers, it can be membrane bound. That is what we expect in Pompe disease. But no, we don't see it necessarily membrane bound. You can see it freely in the cytoplasm as well. So if you just look at the membrane bound glycogen and you don't look at cytoplasmic, you could go in the wrong direction. And this vacuolization in the late onset Pompe disease, there is a huge variability, and it ranges from 10% vacuolization to 75%. So it could be diagnostic, or you could miss a diagnosis if you just look at the vacuolization and membrane-bound glycogen. So advantages of muscle biopsy, it is a direct method. You get a rapid answer. You can measure GA enzyme activity on muscle, you can look at histopathology, and you can get quicker answer as compared to other odyssey of testing. Disadvantages is that the site of biopsy and the selection of the muscle can really affect your results. Lack of glycogen accumulation does not rule out Pompe disease. You can still have Pompe disease, but the biopsy was not done in the part of the muscle where there was glycogen accumulation, because there could be fiber to fiber and muscle to muscle variation. And it is invasive procedure. You need anesthesia for the biopsy, and it needs a very little extensive shipping procedure on dry ice if it has to go to a distant lab or distant expert person. And processing of the biopsy piece is little technically challenged in order to get good histopathology and EM pictures. And skin fibroblast analysis, which has been a gold standard in the past, it is still a way to go in case of difficult cases, especially in late onset cases where you find a variant of unknown significance. And we still rely on skin biopsy to measure enzyme activity and to do some other types of assays. And of course, in skin fibroblasts, you can separate the phenotypes to quite an extent, infantile from the late onset. But the only disadvantage is that it takes too long from the day of biopsy till you get results. You count about 6 weeks into it. And for infantile cases, you don't have that time. So now, as a result of the things revolutionized in the past 10 years or so everyone is going after diagnosis of Pompe disease using blood-based enzyme activity assays. And of course, they are very beneficial. They avoid invasive skin and or muscle biopsies and culturing time that is involved. And you can use dry blood spot assay, which is the blood which can be spotted on the card directly. Or you can take a tube of blood and isolate the nucleated cells. We call it mixed leukocyte assay. and you can use like different, we call it substrates, 4-MU or glycogen, which is naturally occurring in the body, to measure the enzyme activity, or you can make a pure, like one type of cells, we call it lymphocytes, that prep, and then again you can measure the enzyme activity. And the newest method, which is implemented in at many places now, is the quantitation of enzyme using stable isotope dilution, which is using tandem mass spectrometry. It is very sophisticated and expensive method, but the good thing is that you can test many LSDs together here. So the complication with the blood spot testing is that there is a interfering enzyme, which is called maltase glucoamylase, which is active at the same pH, like acidic pH. So you have to block this enzyme by using some competitive inhibitor, which most of the labs are using acarbose, or in Australia they use immunocapture method. So you have to block this enzyme, otherwise you will have false negative results. So the disadvantages of the blood-based assay is that it's a very quick diagnosis, it's good, but you cannot differentiate between infantile onset Pompe from the late onset Pompe, or the Pompe patients which are less than 1 year old but without cardiomyopathy phenotype. They all measure in the same range. There is overlap. And the other thing we have learned is, if there is a carrier of Pompe and there are pseudodeficiency alleles, it's hard to differentiate between pseudodeficiencies with one mutation or without a mutation from the carriers. So it's not a perfect way to pick up Pompe. Good. So we also take help of with the Pompe being a newborn screening reality becoming a reality in the United States, and many states are doing it. We also take help of urine hex4 or GLUC4 analysis. So in the same patients, if we run GLUC4, it really helps us separate the really infantile onset Pompe from the later onset forms. So this is in conjunction with the enzyme activity assay and other things. This is very non-invasive, easy assay to do, and it aids in the diagnosis. So blood-based assays are very convenient, stable during shipping. Turnaround time is very, very fast. We turn it around within 4 to 5 days, and in infantile cases, within 24 hours, we have a result. They're very reliable and sensitive in both infantile and later onset forms. The only thing is that you have to confirm the diagnosis through GAA, gene sequencing, with 2 pathogenic mutations, or a second tissue testing, which could be muscle and or skin fibroblast. So I will switch gears very briefly. I was requested to touch on this limb girdle muscular dystrophy consortium, which has formed in US, and their effort is to do genetic testing on as many patients as they can which have been diagnosed with limb girdle muscular dystrophy. So the reason for them to do the genetic testing is that you make a confirmatory diagnosis, you make a family history and help in the diagnosis and reassure the younger relatives of the proband. Then it helps in the counseling, carrier testing, and reproductive planning. So with all these positives in mind, so LGMD consortium was formed, and Jane Foundation is the main, I think, spearheading the foundation behind it. And it is supported by Genzyme and MD and few other organizations. So it all started in September of 2014. The way it goes is that anyone, it could be patient-driven or it could be a MD physician-driven. If you have been diagnosed with LGMD, you can go online to their website and answer this 18-question quiz, multiple choice quiz. And then this quiz is stored. I'm sorry, I don't think you can read the questions. You don't need to, actually. So these are all the people who have formed the consortium. So you can take the quiz, and then they score the quiz. And if you are eligible, the testing is all free for you. So what they do is then, this is done by Emory in Georgia in molecular genetics lab. They ship a saliva kit to a patient's residence, And then the saliva kit comes back, they isolate DNA, and then they run LGMD panel, which has 35 genes in it. And all testing is done in the molecular lab at Emory, and it is a clinical testing, and clinical report is issued. And this is just like a list, you don't need to read it, but Pompe is one of these LGMD panel genes. So they have included 35 genes in there. So far in 1 year, as of today, they have received 1,500 samples, and they have reported results on 550, about 37% of them. These slides were shared by Emory Group with me, thank you to them. And out of these 37% which they have reported, about 40% have a definitive or likely diagnosis, and about 25% cases have one pathogenic mutation or variant of unknown significance. So there is still not a clear-cut answer for everything, but they really emphasize that this is not the only way. You have to have a functional assay in order to prove that what you found is actually causing a disease. And in Pompe, of course, enzyme activity is the only functional assay. And 8% of cases had no identified variant in these 35 genes, though they were given a diagnosis of LGMD, but they did not find any mutations. So they have picked up 2 cases with GA mutations and diagnosed them with Pompe. 11 cases with only 1 GA mutations, and these are their websites. If anyone wants to contact them, can contact them directly for help. This is the last one for me. And so the lessons we have learned is that Pompe gene is a very, very polymorphic gene. There are too many variants, many new novel mutations, a new variant is found in every week, everywhere. And you need to have a very reliable and good enzyme activity assay in order to correlate it with the variant. And this is the only functional assay we have currently to prove it, that it is any variant does cause enzyme deficiency. And any lab getting into the GA gene sequencing, it's very important for that lab to familiarize themselves with the gene thoroughly. What are the common mutations? What are the polymorphisms? If you find one mutation, what is the next step you will take? And with this slide now, I will hand it over to Stephanie, and she'll take you through the genetic counseling issues associated with Pompe.
Thank you very much. That was excellent.
Hi, thank you for having me. Dr. Plotz said I have about 5 minutes, it sounds like. So he said quickly. So I'm going to go through a few issues, but if you have any questions afterwards, I'm happy to talk specifically if you have genetic counseling issues. And also Lauren Bailey, one of our genetic counselors from Duke who runs the metabolic clinic, is here too. So either one of us are happy to talk to you. So just quickly, the GAA gene is located on chromosome 17. And as Deeksha mentioned, there are a number of mutations. Like Dr. Kimonis suggested, a lot of these mutations are private family mutations, so they're only seen once in a family versus a number of times in different individuals. But there are several mutations that are seen in specific populations, especially populations that are a little more closed, for example, the Dutch population. So why is genetic counseling important? Why do we consider genetic testing? One of those reasons is to confirm a diagnosis of Pompe disease, and Deeksha touched on that very nicely. But also we have the question of predicting phenotype. So if you're diagnosing a young child or a younger adult, do we see a mutation that indicates more late onset type disease or more infantile type disease? And thinking about that can aid in interpreting genetic testing results. Also, another important point I'm going to talk through briefly is considering multiple generations affected in one family. This is something where we need to really think about a very good targeted family history and asking appropriate questions, and then also offering genetic testing to any family members that might fulfill the diagnostic criteria. And then finally, in genetic counseling, we provide a lot of treatment coordination and management. I'm not going to necessarily go into that, but we're always here to help facilitate appointments in the system. So when we think about predicting genotype-phenotype correlation, one thing that we do know is that generally phenotype presentation for infantile patients is similar among family members. So if babies within the same family carry the same genetic mutations, we usually see that they present at similar times, versus in late onset where there can be a wide variability in age of onset with family members. So this is just one case I want to point out for physicians, but also for some families here. This was a 35-year-old male that we saw in clinic. He was initially picked up on the Council prenatal testing screening panel. So briefly, for people who aren't familiar with that, this is a blood test that's often offered to families during pregnancy or prior to pregnancy. It has a list of maybe 100 different genetic diseases on it. But the point is that each genetic disease might only be detected by a certain number of mutations. Each gene isn't necessarily sequenced. So you're only looking at very specific gene mutations that could cause the disease. So for the Council testing, the one gene that they look for is the IVS splice site, the late onset mutation in the US. So this patient was diagnosed with late onset Pompe disease by having 2 copies of the IVS splice site. So he was told he had late onset Pompe. So we did verify those results in our lab by sequencing the entire gene just to make sure that we didn't see any other gene changes, and we did find those 2 same genetic changes. So what's interesting about him is that he was very healthy with no actual apparent symptoms or really signs of Pompe disease. He was athletic, he participated in marathons and triathlons. He did have some mild leg cramping and lessened endurance in running, but he was running marathons, so I would think that that's not all that uncommon. And he wasn't on enzyme replacement therapy at the time that we saw him. So we did have him participate in a multidisciplinary evaluation, including physical therapy, pulmonary function testing, and also we have a whole body MRI protocol that we do where we look at fat infiltration, which is a whole different talk. But in general, that was a normal scan. We did talk to him very specifically about his family history. His brother was also identified as a carrier of the splice site that he had 2 copies of. His father had hemochromatosis, therefore the patient was an obligate carrier, but there was this cousin with this muscular dystrophy. So I'm not necessarily going to answer these questions, but these are some of the things that we think about. Would we consider this Pompe disease? What phenotype would we predict for him for the future? And what follow-up is recommended? So at this point, he still is not on enzyme replacement therapy, and what we recommended to him was to follow over time these different symptoms and signs, and to be in touch with us for full evaluation in the future to continue to look for signs and symptoms. Okay, finish very quickly, 2 minutes? Okay, 2 minutes. So this is, I think, also a very important point for families here is the multiple generations affected in one family. And we need to think about this as we're thinking about when newborn screening, especially having children diagnosed with infantile onset. So quickly, the case here was a baby diagnosed at 3 months, definitely had 2 mutations. But then a year later, mom was tested, and she was found on enzyme level on blood was within the affected range, and then she also had 2 mutations. However, her mutations, she had 1 infantile onset mutation that she had passed on to the child, but she also had a late onset mutation. So the baby had infantile onset Pompe, and the mom had late onset Pompe. Interestingly, we looked very closely then at the other siblings, and the siblings also turned out to have late onset. 2 of the 4 siblings had late onset Pompe. However, they did not have the same genetic changes as the infantile patient or the mom. So it's semi-confusing, but in general, mom has a late onset mutation and an infantile mutation. Dad has an infantile mutation. The baby inherited the infantile mutation from mom, infantile mutation from dad, and then the other 2 siblings inherited the infantile mutation from dad, the late onset mutation from mom. So there's 2 late onset children in the family, 1 infantile onset child in the family, and mom also has late onset, but a different combination of mutations than the 2 children have. So the point of that is that we need to think about families very specifically, and if you have parents, sisters, brothers, cousins, talk to your doctor very specifically about that and make sure that those things are taken into consideration. So I'm going to finish. I'm happy to answer any questions. Prenatal testing is available if anybody has any questions. If you have Pompe disease and you want to have a baby, you want to know what the risk is of having a child with Pompe, do full sequencing. Don't do just targeted mutation testing.
Thank you for this really excellent presentation.
Thanks.
Our next speaker is Dr. Priya Kishnani, whom I think you all know. I'm going to squeeze you too.
So good morning, everyone, and I will try and stay on time. So the topic I was asked to speak on was on patient management and the current standard of care. So I really wanted to start with a few slides describing that since the advent of approval of L-glucosidase alpha in 2006, there have been series of publications on management guidelines for individuals with Pompe disease. So you'll see that right in 2006, there was the US guidelines from the American College of Medical Genetics. There were also physical therapy guidelines published then. In 2008, there was another set of guidelines. In 2009, the Brazilian cohort or group of physicians published guidelines. In 2010, we recognized about the CRIM-negative status in infantile Pompe as a poor prognostic factor, so putting that in the algorithm. In 2011, the college again had LST guidelines for the pre-symptomatic cases. Then there was guidelines published in Spain. Then the group of neurologists in the United States had some for the late onset cases. Then there was the guidelines for immune tolerance induction for CRIM-negative Pompe, and then South African guidelines, and then recently guidelines from Europe. And now we're working on newborn screening guidelines in the United States, and we're expecting a whole supplement in pediatrics, I think, which encompasses 6 articles because of the advent of newborn screening in the United States. So I really wanted to point out that there are multiple guidelines, and so I know we have representatives from different parts of the world here. So please do look for the guidelines that are specific to your region. If you don't have guidelines for your region, please look up these guidelines so that you can use them to help treating physicians and also to guide reimbursement policies, because these guidelines have been extremely helpful. So with that, I also wanted to now talk about what do we know today about L-glucosidase alpha. So another take-home message is please read the package label, the myozyme or the lumozyme package label. There is such invaluable information there. So in short, the approved dose is 20 milligrams per kilogram every 2 weeks. There are no contraindications to its use in individuals with Pompe disease. There are some warnings and precautions, such as reactions, immune-mediated reactions, or the risk for hypersensitivity or reactions like one would have to a bee sting allergy. For the infants, there are some challenges with cardiorespiratory failure, so do not overload the volume in which the infusion is given. The other part is that it needs to be given over a period of approximately 4 hours. Please use the inline low-protein binding filter, because without it, your risk for having a reaction is much more. There is guidelines on how the infusion rate needs to be ramped up. And yes, there are some centers and some groups where it is ramped up more than what is in the guidelines, but please follow these initially to ensure that there are no reactions. And please also have your treating physician referred to that package insert, which gives so much information. Because today we have patients in more than 60 countries which have received L-glucosidase alpha therapy. And so I think these guidelines, as well as the package insert, can be extremely helpful. I also would strongly suggest looking at the minimum recommended schedule of assessments for the Pompe registry, because this again gives a lot of good information on how often certain tests should be performed. And it also talks about antibody testing, and I think we'll be talking about this in later sessions, but once again, it's there in the package insert, it's there in the guidelines, and still we continue to see that there are individuals with Pompe disease who are not getting this routine follow-up of care. So as we talk about the management and the current standard of care, I really want us to recognize today that we are moving from an era of patients who are diagnosed because of clinical symptoms and signs to now the era of newborn screening for Pompe disease in many, many parts of the world. There are many questions at hand which I think are going to be answered through the day today and tomorrow. Who's going to manage? When are we going to start enzyme therapy? When are we going to stop? What is an appropriate dose of enzyme therapy? What is the role of other interventions? I'm not going to touch on these today in this particular talk, but I'm sure we're going to hear this through the day. I want the audience here to know that Pompe disease, there's multi-system involvement. And when I say multi-system involvement, the purpose of my saying this is not to burden you by thinking that you've got multiple things going on, but rather that we need a team approach of physicians to care for the various aspects of the disease, and then someone who's overseeing the entirety of the care of these individuals. So we have pulmonary challenges, which you heard from Dr. Bach. There are gastrointestinal issues. There are vascular features of the disease. There could be eye manifestations, cardiac disease, and of course in the muscle disease as we understand it, there was some discussion about the central nervous system and peripheral nervous system involvement. We know that some of our children have speech challenges, that they have hypernasality, and then we're recognizing even tongue weakness. So the purpose again is that please look at the disease management guidelines, because treatment has to be given as part of a multidisciplinary team approach. It should be really provided at centers with experience, and the outcome truly can be really positively impacted when you have good initial and comprehensive care to provide the guidance then for the local treating physicians. And that we should now recognize that we've got infantile survivors who are living to be adolescents, but their issues are not just now an extension of what we see in late onset Pompe disease, rather that there are certain features which are very characteristic of infantile cases and separate and different from the late onset Pompe disease cases. So this really is to tell you that at the center of this is you as the parents, the patients and the care coordinator, and then working with a group of experts with different areas of disciplines of expertise to provide overall care to the child and or the adult. Now, how do we really follow these individuals? I think you heard from Dr. Bali about the use of the CPK, the use of what we call the liver enzymes, but these are truly also muscle enzymes. But also there is a very valuable role of biomarkers, the urine hex4 or the GLUC4, which is a breakdown product of glycogen. I think this is not single time points, but rather following the patients and the trends over time that can give you an understanding of response to therapy. So you can see here, there is no pointer here, right? That this is the upper limits of normal, and then if you follow these patients over time, you can really track someone who's a good responder or someone who would have a more limited response to enzyme replacement therapy. Today we've also got the role of imaging, the role of whole body MRI, the role of muscle ultrasound, and other biomarkers which we'll hear about, but these are additional tools which help us when to initiate therapy, how to manage therapy, and also how to give realistic expectations to our patients and their families. I think for infantile Pompe disease, we know that no delay in diagnosis. That's why the whole purpose of newborn screening, and of course to identify later onset cases in a timely manner. No delay in treatment initiation. I think knowing the cross-reactive immunological material status, we know this today, it has to be recognized, and that sequencing is a very important part for diagnosis and for the CRIM, or the cross-reactive immunological prediction. But moreover, as we enter into the arena of newborn screening, there is what we also understand the pseudo-deficiency allele, which is where you have a low enzyme activity outside the body, but truly the patient does not have a deficiency. And then to follow the antibody titers closely in infants, as a large subset of them can develop high and sustained antibody titers. And so every month in the first 6 months, and then every 1 to 2 months. I think we're going to hear more about this through the rest of the day. So this is an algorithm that once you've made a diagnosis, this is for the infantile case, once you identify someone who's CRIM negative, then I think it behooves us, this has become more a standard of care of immune tolerance induction and monitoring the antibodies and checking how these infants do over time. Now let's talk about the adults, or the rest of the disease spectrum, so anything outside of classic infantile Pompe disease. There are consensus guidelines on this from the US, also from the European groups. The idea is, I'm not going to go into the details here, but there are guidances on when to initiate therapy. Whether these are appropriate, whether these need to be debated, I think this is a question that newborn screening and follow-up of those children and adults is going to tell us. But there are guidances at this point. That is the message I want to give. And now let's look at certain specific issues. We understand heart issues are a finding in infantile Pompe disease. So doing regular chest x-rays, doing the echocardiogram to see what the heart muscle thickness is, doing what we call 24-hour monitoring of the heart rate, or the ECGs, is important. But I also want us to recognize that some of these children, as they're living and getting older, may have a normalization of the heart size, but still are at risk for developing arrhythmias and or heart rhythm disturbances. So this really should be kept in mind in the monitoring of the child with Pompe disease. And now let's think about the adult, or the rest of the clinical spectrum. Even there is a recommendation to do a baseline ECG, to get a baseline echocardiogram, and then to follow up as is clinically indicated. I think, as you heard earlier during the day, that there can also be vascular involvement or blood vessel involvement, including vessels of the brain, or an example of which is the basilar artery. At this point, there are no clear guidelines of how often and when to do imaging, or what we call MRA, or angiography of the blood vessels for the brain, or an MRI in adults with Pompe disease. But clearly, it should be done if there are signs and or symptoms which are suggestive of any kind of neurological involvement. So here I really also want to show you how we have vessel involvement of the ascending aorta, or the large blood vessel of the heart. And so when an echocardiogram is done, not only to look for the heart muscle thickness, but also to look at the measurement of the aortic root. And I hope you can appreciate that there is an increase in the thickness of the ascending aorta here. Now let's talk about the musculoskeletal issues, and I'm going to touch upon this very briefly. The main idea is, please work with a physical therapist, and please work with a physical therapist who has experience with neuromuscular disorders. The idea is to prevent contractures and to prevent the onset of deformities because of disuse or underuse of certain muscles. And please use equipment as needed. For the children, we talk about the use of ankle-foot orthosis, so to help to stabilize the foot. You can use different kinds, like knee extension splints, thigh binders, as you can see here, a combination of thigh binders as well as the ankle-foot orthosis. And then there's a series of different adaptations or adaptive devices that can be used to prevent the fatigue of certain muscles. There are lifting transfer devices. There are things to help with shoulder muscle to prevent weakness. There's what's called the NADA chair. There's a seat lift. There's the use of the cough assist that even Dr. Bach talked about, and then also the use of medical alert devices, especially for those who have significant respiratory or pulmonary involvement and are at risk because if they had a fall, sometimes they cannot even get themselves up, and we've had some cases of suffocation and very serious sequelae because of not having this medical alert device to help them out. So there's lots and lots of adaptive devices. The idea is not to give you all of them here, but to work with your physical therapist to use it. And I'm going to show you this video just to give you an example of how simple devices can help. So here is an adult with Pompe disease, and you can see that he's using hiking poles, which gives him a lot of stability as he walks. So this is without the use of the hiking poles, and the other is with the use of the hiking pole. And the second video is going to show you how the hydraulic seat cushion really facilitates the lift off from sit to stand. So pay attention to that, and that he's putting less stress on his trunk muscles. So here is the patient now sitting down, and as he gets up, there's less use of trunk extension. I think there are exercise guidelines, but the main idea is to use submaximal aerobic exercise. Overuse of muscles can be very harmful, and avoid the overwork, weakness, and excessive fatigue. And once again, then we have osteopenia and fractures throughout the Pompe population. The idea is good nutrition, attention to calcium, phosphorus, vitamin D, use of the DEXA scan as needed, and careful handling, of course, for the infant, and working with a physical therapist as needed. Then we talk about neuromuscular assessments. We talk about neuromuscular assessments. The idea is not to fatigue the patients when they come to the clinic, but rather as a way to monitor patients over time. And so the physical therapist and the team can work with different strategies, which can include muscle strength measures, functional measures such as the 6-minute walk test and other timed measures. This is more to assess you over a period of time as you're seen in the clinic. I think as we focus on the musculoskeletal aspects of the disease, we often forget about gastrointestinal issues. There's a high prevalence of this in this population, and that it can result in a risk for aspiration and also decrease in the caloric intake. So there is a big role for nutrition, and it becomes a vicious cycle in the infant for poor weight gain. And if we can cut this by working with the occupational therapist, I think it's extremely helpful. And then this also is an issue in the adults, both weight loss as well as weight gain. So working with a dietitian with experience is very helpful. And once again, the whole idea is good nutrition, including both micro and macronutrients across the disease spectrum. I won't touch on the pulmonary function measures because this was done by Dr. Bach, but do not forget the general medical care aspects: hand washing, routine immunizations, use of the flu shot, and careful use of over-the-counter medications, avoidance of statin drugs, avoidance of medications that suddenly increase the heart rate. All these can be very harmful to the patient. And very quickly about the immune issues, again in 2 slides, that there are 2 types of challenges. One is the hypersensitivity reactions, and the second is the body making antibodies to the enzyme, which are 2 different sets of challenges but need to be tackled. So we need to know how to manage these infusion reactions, use appropriate facilities to deliver the enzyme, and then know that there is testing that's available. Genzyme does provide these kits for the IgG antibody testing, as well as for those who are at risk for hypersensitivity reactions. So please work with your local Genzyme contact for this. And now we have newborn screening guidelines, which I'm very excited to say that in 2016 we're going to have a series of articles on this, of what are the considerations for the classic infantile patient, as well as the considerations for when to start therapy in late onset Pompe disease. And with that, I want to close. Remember that enzyme treatment is only one aspect of the overall care. We are learning more about the disease, and we learn every day from each one of you. We need to involve multiple specialists. The families and patients often need to serve as advocates to ensure that the treatment guidelines are followed in their care. And we truly are in a very exciting time in the field of Pompe disease. These are my acknowledgements for Duke, and also to the AMDA and to all the patients and their families, many of whom are here, especially to Tiffany House, to Marcia Zimmerman for the tireless efforts that you all have put in to make this conference a success. Thank you.
Thanks, Dr. Kishnani. Dr. Smith, are you here?
Okay, good morning. I'd like to first start off by thanking the AMDA and the conference committee for inviting me here to share some of the updates that we have on the work we're doing with diaphragm pacing for Pompe disease. And there may be some questions going through your mind. What is diaphragm pacing? I'd like to answer all these today if I can. Why would we use it in Pompe disease? Who might qualify clinically for a diaphragm pacemaker? How is the pacemaker used to condition the diaphragm to get better at breathing? How have patients responded so far? And then looking ahead, where are we going? What additional questions do we have? And so I want to start out with this slide, and forgive me, I know we've got quite a varied level of background knowledge and information on Pompe disease and breathing, so bear with me if I'm just going a little general at first. But your diaphragm, in order to contract and to do the work it needs to do, it needs to get a signal. And that signal comes, it's been coming like all morning long, about 12 to 20 times a minute, without you even thinking about it this morning. You've been thinking about all this great content, and the whole time, that diaphragm has been working. It gets signals regularly from nuclei in the brainstem. And there's an intersection there at about the third through the fifth cervical levels of the spinal cord at the phrenic motor nucleus. And then at that intersection, the phrenic nerves take hold, and you can see those in yellow here in this slide. All right, and they course down through your thorax, and they connect at the diaphragm. And that's how the diaphragm receives its message from the brainstem to fire and to generate the work of breathing. All right, so at the University of Florida, we use, there are different models, but we use a diaphragm pacemaker made by Synapse. We have no affiliations with them. It's just what our surgeons are trained in. And this is a device that's indicated for neuropathic ventilatory failure. So the diaphragm is not receiving the message it needs to receive. This is a laparoscopic surgical placement. 2 electrodes are placed near the active area on the right side of the diaphragm, and 2 electrodes on the active area at the left side of the diaphragm. And then there's a 5th reference electrode. Those are externalized, usually kind of in the right side of the abdomen, and connected to an external pulse generator that delivers the stimulus to tell the diaphragm and that active area of the phrenic nerve to depolarize, to generate an action potential, and to do the work of breathing. And so really the goal, the rationale for this is to, as we say right here, to facilitate neural input to the diaphragm so it can do its work. I'm not going to belabor this point. We've heard a little bit that there's dysfunction in muscle, and you're a savvy audience and you know that. We also have evidence, a lot of evidence in animal models, and a little bit of patchy evidence in human models. It's just a little bit of a harder thing to do methodologically, that there's appreciable neural pathology as well. This is an example of the intersection kind of between the white matter and the gray matter in the phrenic motor nucleus area of the spinal cord of a 18-month-old with Pompe disease. And we can see myelinated axons off to the corner here. And then these large little starred areas, those are phrenic nuclei. And when we blow up those nuclei, when we look at what they look like under a higher affinity, we can see that they look swollen in appearance. And the nuclei are shoved, the nucleus of the cell are kind of shoved off to the corner. And that's the appearance, the morphology of a sick motor neuron. We also have some evidence that the connection between the neural axon and the motor end plate of muscle, it's uncoupled. And so what that means, I think we can demonstrate that on this image, but on the right side of the image, this is from a mouse, we see this glowing green. That's actually the presynaptic area of the neuromuscular junction, the neural area of the neuromuscular junction. And contained within that little network of green, we see some red staining, which that is a specific alpha bungarotoxin, which it stains for the motor end plate of the muscle. So we see this coupling between the muscle part and the neural part. And that's how it should be. And what we see in Pompe, this is a Pompe mouse, we have a human neuromuscular junction tissue as well, is we see a loss of that green presynaptic staining, and we see this diffuse staining at the motor end plate. So the coupling is lost between the muscle and the nerve. And so based upon a fairly significant body of animal work and a growing body of human work, a conceptual model has been developed about the mechanisms that lead to the need for breathing support in Pompe disease. And let me walk you through this one. So we've got 3 lines on this figure. One is representing, this guy here is representing muscle function, muscle contractile function. This more dashed line represents neuromotor output. This is much easier to measure in an animal model because we can directly measure neural recordings in animals. And then the hybrid of this is this neuromuscular function. What actually, when the muscle and the nerve are working together and we ask the animal or the person to breathe, what do we get? So we're most interested in this neuromuscular function. And in stage 1 here, when patients and mice are asymptomatic and things are working pretty well, we see that we get a high level of output, both in the muscle and the nerve, and a high level of function, a high level of breathing. But there comes a point when we can measure respiratory symptoms, and we may be able to measure some decline in contractile function earlier in muscle. Initially, we may actually get a compensatory increase in neural output. We're trying to maintain function, so the nerve is working harder to keep the muscle output what it can be. But eventually, we see pathology both in neural and muscle, and we reach a point where support is needed in order to sustain function. Okay, so that's an easier thing to do in a mouse with Pompe disease than it is in a person with Pompe disease. But we're growing some evidence that suggests that these are happening in people as well. And I just want to show you this image of a phrenic stimulation test. You might have heard about these, you might have read about them in the literature, and they're done in a few places here in the US and in the EU as well, and South America. But this is actually a phrenic magnetic stimulator, and our patient has swallowed 2 small, rather flexible pressure sensors, and I think we can maybe see, can you see that tiny little line kind of coming across the, you may or may not be able to see this. They're tiny, they're very thin, they're very flexible. But those 2 pressure sensors, one lands in the esophagus, the other lands in the belly, and they measure pressure above and below the diaphragm. So unlike a maximal inspiratory pressure test where we take that big breath and we get this one reading, we can measure what the diaphragm specifically is doing. Now, the wands that I'm holding off to the side, those come from a magnetic stimulator. They're tucked right underneath the chin there. There's another model that can go in the back of the neck. Those are areas where the phrenic nerves are relatively superficial, where we can cause those nerves to depolarize, causing the diaphragm muscle to twitch. Okay, it feels kind of like a hiccup that you didn't make. And the arms may also twitch, depending on the strength of the stimulation. So we can look at muscle and neuromuscular responses to stimulation with this twitch. And in fact, we've done some of that. So I want to guide you through this. On the left, we've got pressure. This is going to be sort of our estimate of muscle contractile function. And on the right, this is really more neuromuscular function. It's recording from the EMG. It's recording the motor unit response, the muscle action potential response on EMG. And what we found, our patients, our volunteers here in red are healthy controls, and then we've got dark blue, folks who use no assistance to breathe. Medium blue, they use nighttime assistance to breathe, and then in the kind of the light periwinkle blue, these are folks who are using daytime and nighttime assistance to breathe. And what we find is this sort of, when we measure absolute values, function declines according to the amount of assistance that's used, both for pressure and this neuromuscular output. When we look at pressure and output in terms of percentage of the peak response that we're able to get, this helps us distinguish recruitment of motor units a little bit more. And what we find is that there may be some difficulty with muscle and with the motor unit generating an action potential and generating some pressure, but for the most part, recruitment is fairly typical, except for our lightest colors, both on the left and the right side, which tells us that recruitment becomes problematic. So in getting motor units to be recruited at lower levels of stimulation is a problem. And that's a problem for people with breathing because we don't use a high level of stimulation to breathe, breath to breath. We do for maximal inspiratory pressure tests, but if we had to generate a large amount of our maximal capacity just to take in a breath, we would fatigue very, very quickly. And so that's where diaphragm pacing really, we think, comes into play. If there is a neuromuscular component to the loss of breathing function over time, and if using the ventilator for longer periods of time may be associated with reduced ability to recruit phrenic motor units, then perhaps diaphragm pacing can be used to bypass this reduced recruitment at the phrenic motor system. So let's talk about some clinical candidates. First of all, the surgeons make those decisions. I'll never be a surgeon, and it's their decision and their evaluation who they think is the ideal candidate. Medicare tells us that these are the qualifications at a minimum. All right, so we have to meet the criteria for clinically significant restrictive thoracic disease. So we have to have a certain level of forced vital capacity, any one of these four conditions, presence of hypopnea or desaturation with sleep, chronic daytime hypercapnia, or a reduced maximal inspiratory pressure test. And all of the patients we've worked with so far have had all of these and are using both nighttime and some daytime assisted ventilation. So I've showed you a little bit about what the diaphragm pacemaker, how that's implanted and how that happens. So now you've got 5 wires in your belly, all right, coming out to a generator that's delivering a stimulation. How do we get from that to being able to do more? And so there is a bit of a conditioning process. The pacemaker was designed originally for people with spinal cord injury, people who don't have sensation below the level of their injury. So they might not feel that pacemaker generating those stimuli. So we begin at very, very low levels of stimulation, where really it's just kind of, you're just starting to feel it. And we go for very, very short periods of time, 10 to 15 minutes, a few times a day. And we gradually want to increase the time folks pace. Every week or two, we want to turn up what that intensity is. And then we also want to do those types of activities while the patient is either on reduced or removed support, so the patient gets used to using this input from the pacemaker with the goal to use the pacer 24 hours a day. We measure several things. We measure a lot of the clinical tests that Dr. Bach talked about earlier, the end-tidal CO2, saturation, vital signs. Surgeon may order some clinical labs at his discretion. We also use the EMG to look at the activation of the diaphragm, measure tidal volumes, of course, minute ventilation, and whether patients are, how long patients are using the ventilator during the day. What we found is at baseline, we take several measures. This is a pressure sensor in the belly, and every time the ventilator, this is a flow generated by the ventilator, every time the ventilator moves air into the lungs, it pushes down on the diaphragm and creates the pressure sensor in the belly detects that. But what we find is our patients on full ventilator support, they may not be using their diaphragm at all when they're getting all the support from the ventilator. So we see really no active inspiratory bursting on EMG. And so this just makes that point as well. So this is from one patient, looking just at the right side here, just for clarity. Resting on the ventilator, we really don't see any EMG activity, raw EMG and integrated EMG. And then when we take the patient off the ventilator, we start to see some inspiratory, some phasic bursting with the patient's inspiratory attempts. Now what you can't see on this image was this patient could tolerate about 2 minutes and was working his hardest, okay, and really working very, very hard to generate inspiratory volume without assistance, but the diaphragm wasn't helping that much. And then we get even more recruitment of the diaphragm with a maximal inspiratory pressure maneuver, which we would expect. That's our best effort. And so we repeated these measures over time. We have electrodes in the diaphragm that enable us to look at this over time. And what we found was as we went from post-op day 5 on the left to post-op day 80, we see a much more robust bursting of the diaphragm, just with spontaneous breathing on the ventilator. Okay? We see that also with unassisted breathing, and then more recruitment again in with maximal inspiratory pressure. So we have results right now. We have 4 patients that the University of Florida has paced. So I can give you results from those 4 individuals. And this is root mean square of the diaphragm. It reflects how active the diaphragm is. And this is while the patients were on the ventilator. And we see the patients were not as active on the ventilator initially, but with use of the pacemaker at 1 month, we see more spontaneous bursting from the diaphragm. And we see also that tidal volume, this is unassisted tidal volume. We also see, this doesn't look like it's that much of a difference. The average is about 20% improved, though, at 1 month. And then we begin to see, we don't see big changes in time off the ventilator at 1 month, but by 3 months, we see a large increase in the amount of time patients spend off the ventilator. Caveat, this light pink measurement actually was just taken at 2 months. That individual's not quite yet at the 3-month point. But we're encouraged that, that over the course of time with conditioning, the patient is able to maintain ventilation using the pacemaker off the ventilator. What do we know? Well, we know 3 of our patients have used this technology for at least 2 years, and the benefit is maintained at least that long, longer in some patients. We do have an ongoing study, and we're grateful to the AMDA for that. We're looking at how this is changing patients' management, their daily management of their lives. One individual said that they have so much more energy now than they used to. They feel like they've got so much more get up and go, more spunk. At the time off the ventilator, one of the subjects, we've got 2 children and 2 adults. One of the subjects just doesn't want to go back on the ventilator at night. So just feels good all day long. Is it time? Okay. We're having some other great benefits. We've got some more questions to ask, and we are very grateful to our patients and the AMDA. Thank you.
And our final speaker speaker in this session is Dr. Ans van der Ploeg, whom I think all of us know.
So, I will be the last speaker in this session, and my presentation will handle about safety and efficacy of exercise training in adults with Pompe's disease receiving enzyme replacement therapy. And in fact, I'm giving this lecture on behalf of Linda van den Berg. She was planning to give this lecture. She's one of my PhD students, has finalized her PhD. And on behalf of Marijn Favier, who is a physical therapist and also PhD. Linda and Marijn both are movement scientists, and Linda is also doing currently sports medicine. So she has a lot of expertise, but I will try to do it in her place. So if we look at benefits of exercise training in healthy persons, then exercise training has beneficial effects, of course, on the skeletal muscles, where which you want to train, the heart, which has to exercise more, the lungs, bone density, because there is a strict relationship between muscle strength and bone density. That's also a publication that we had on bone mineral density in relation to muscle strength, and well-being, psychological effects. Exercise training in healthy persons has shown to increase muscle fiber size. It can also change the fiber distribution in type 1 and type 2, and can also increase possibly the amount of fibers. And thereby, through these concerted actions, it can increase the muscle strength and improve muscle function in healthy persons. But how in patients with Pompe's disease? In the past, there were a lot of concerns about exercise training in patients with muscular diseases in general, and also in Pompe's disease. And one wondered whether it was safe, and whether you could train the muscles, and whether it would not harm the muscles, and whether it would be counterproductive. So that was reason, and we got a lot of questions, and that's also a reason to do this study. We were not the first who gave attention to exercise training. I need my glasses, otherwise I can't see it. The first, I think, a very well-known study in Pompe's disease is that of Slonim. That is quite a long study, but that was a study that combined exercise with nutrition. So it was not exactly known what is the effect of the nutrition, what is the effect of the exercise. Then there is a study, in fact, that was mainly devoted to enzyme replacement therapy, the effects of enzyme replacement therapy in 44 German patients by Benedict Schoser here, and he was the lead an important author on this paper. And in this study, there were 5 patients who also trained during the period that they received enzyme replacement, and these were the top guys in the effects of ERT. And then there is a very small study also of Tersis, and Tersis is a Greek group that also showed that exercise might improve muscle strength. But all of these studies are small, so this was reason to do a larger study. Now, this study has been published in the meantime, and there are 2 publications, one more on the parameters and one more on the patient-reported outcome. And what were the aims of the study? That is to improve the effects of ERT on endurance, on muscle strength and muscle function. Also, we looked at body composition by DEXA scans to see whether there was a better bone mineral density and well-being. And to produce an effect, that was also an important goal, to produce an evidence-based guideline for exercise training for patients with Pompe's disease, and also to implement standardized exercise training programming in addition to ERT. So with the study design, we decided to include patients over 17 years, and to have them in a more or less stable situation. We wanted them to have at least 1 year of ERT, so that we could rule out the effect of ERT as much as possible, so that we could see how it worked. We also had a part placebo in it, but that is something that I will, or placebo for training. They had to be ambulant, so we focused on the good group of Pompe patients, so in fact the best, and they had to be free of ventilator. And we decided, we also had a long discussion on what type of training program are we going to do. And in fact, we ended up with a combination. And the reason for that was that we only have, although we have quite a lot of Pompe patients, we have about 100 adults with Pompe's disease, but if you want to do a training study in a homogeneous group of patients, then you need numbers. And so we decided to do a combined study. So part was endurance to improve fitness. Part was resistance training in order to target the affected muscle and to improve strength. And the other part, that was the most challenging part, is the core stability. And that was to ameliorate proprioception and also to affect the strength of the muscles that you couldn't target with the resistance training. So this is more or less how the program looks like. First, the patients got a VO2 max study in the laboratory. That means that they had to do a kind of endurance test, that they had to do first a kind of run-in period of 5 minutes, and then they had to start to work on an cycloergometer with a ergospirometer, so that you can measure the workload and the oxygen that you consume, and at the same time you measure the heart rate, and at that moment you try to get these patients at a maximum workload, so that each time 5 to 20 watts is increased dependent on how much the patient can endure until you reach the maximum workload and the maximum heart rate and the maximum oxygen consumption, and that's at the same time is what you measure after 3 months of ERT. And then with the training program, there was an endurance part as shown over here. And this endurance of this program was done 3 times a week. And it took about 1 to 5 to 2 hours per time. So it was quite a time, an investment. So here for your to see it more closely is that the endurance training was done at moderate intensity. It was for 50 minutes, and it was on a level of 60 to 80% of the maximum heart rate that was measured in the laboratory. The resistance training was also done with moderate intensity in 3 sets of 15 to 20 repetitions. And you see on the right side here what type of exercises were done. Seated rows, chest press, biceps curl, leg press, leg curl, hip, and hip extension and hip abduction. And here the core stability at the lower part. Do I also have a pointer? But at the lower part are the core stability.
I think the pointer
it's over here.
Okay. Seen.
Yeah, it's over here. Yeah, here the core stability, and that is 3 times 30 seconds. And the endurance training was done, then the resisting training, then the endurance training, and then the core stability. So before we did this program, we trained the physical therapist that worked in specific medical physical therapy settings, and they came to Rotterdam and they had this kind of training, and then they started to work locally with their patients, and it was a training study for 12 weeks, as mentioned, 3 times per week. There were 25 participants, and it was supervised by Linda and by Marijn, and they leased a car for this so that they could go to the various locations to see how it worked. And that's possible in the Netherlands. It's potentially more difficult in the US, but that's the advantage of living in a small country. So and the people on the right side are Marijn at the top and Linda at the bottom. So in total we included 25 patients, but for 2 patients it was too strenuous and they decided to discontinue the study. In total there were 12 males. The median age was 45. The disease duration was 16 years, and you see the range. And the median duration that these patients already had ERT was 3.1 year, with a range of 1.3 to 6.5 years. Patients had no walking aids and no ventilation. So what were the outcome measures? We looked at safety, at aerobic fitness, at muscle strength, muscle function, core stability, mental health, fatigue, pain, activity, and participation. So first, our first concern was the safety, and also for this reason, CK was monitored, and also the patients were called by the two researchers to see whether everything was okay with the patients. And what was observed that in the first week when they came at the physical therapist department, that 2 had a high CK and fatigue and muscle soreness, but happily this subsided and they could continue without further problems. And we didn't see any further increases in CK in the other patients, so we concluded that it was safe. So then the results after 12 weeks of therapy, what you can see, and it's a little bit a busy slide, but if we first go to the maximum workload, you see that the maximum workload increases, and that's significant, that the heart rate remains the same, and that's very important because that gives you an idea that they perform maximally. The peak oxygen uptake also increases, the ventilatory threshold, and what was one of the other parameters that we measured for endurance was walking distance, and also this improved in these patients. Muscle strength, there was a slight increase in muscle strength, and that mainly concerned the shoulder abductors and the hip flexors. And what was really, what I found myself the most challenging part was the core stability. But what was interesting is that first patients thought that it was a little bit strange to do these core stability items, but when they learned to direct their muscles, because some patients didn't use their muscle for such a long time, they improved and they could control it. And I know that Wilma told about it 2 years ago. How you experienced it, yeah, and that you also managed, I can remember, yeah. Okay, and now what was observed in the group, that everybody was able to perform the back bridges, that side bridges, you can see that there were a number of people who gradually, that are more people who continue to, were able to do the various exercises. And also that we saw a significant and large increase in the ability of these patients to do it. And what was measured was the time in balance in seconds. So what was observed, there was improvement in different areas. They were more able to contract the proper muscles, because first some patients had difficulties or many patients had difficulties to direct the proper muscles. Maintaining imbalance was better, and also they got a better strength which they could use for mobility. Then the last slides handle on the patient-reported outcome. We also evaluated patient-reported outcome in this study, and we looked at fatigue, pain, and quality of life. And what was observed, what the patients reported, was that they were less fatigued, and that also they had less pain, so especially the number, that was, I think, a very positive observation, that the number of patients that didn't report pain anymore decreased from 13 to 5 from the 23 patients. And when we look at quality of life, there was not a big difference, but we saw a moderate or a borderline effect on the mental quality of life. And what the patients responded is that they felt better with doing these type of things, and that it helped them physically, but also mentally, to be active and to do it and to make it. We didn't find anything in the physical component score. And then, as last part, what we did is the patient had an activity meter, so we looked at the activity, so an activity graph, it's called, and patients used it had this activity graph for about 3 days, and then, of course, a preset period, and then the activity was measured, but there we didn't find any differences, and also not on the RPECT, and that's the self-reported questionnaire on mobility items. So, in conclusion, it's the first study that proves that a combination of aerobic strength and core stability training has a positive effect in patients with Pompe's disease, and that it can safely be performed, and that it also increases aerobic fitness, muscle strength, muscle function, and core stability with the greatest effect on aerobic fitness and core stability. It also decreased pain and fatigue, and we can conclude that such a program has added value for patients receiving long-term enzyme replacement therapy. We need to extend these studies to patients who are more severely affected. I don't know whether I have a few minutes to give a few
You do have a few minutes.
Yeah? Okay.
You do have a few minutes, and let me just say that we don't really have time for an open discussion after this talk. We'll have a lunch period of 12 to 1, and then the parent perspective with a question and answer, but more particularly in the afternoon session, which I hope you will come to, what we have learned so far at the round table, which Tiffany is going to chair. There will be over an hour for general discussion, and those are clinical matters with patients. They're not obscure science, and we hope that we can handle the questions that have arisen this morning with more time in the afternoon after we've heard more.
Okay, and then I would like to pay a little attention to the patients who do not comply with these type of inclusion criteria. So we had some discussions with the physical therapist and with the two researchers. And first of all, recommendations. Of course, this trainings program is done 3 times a week, and we were very happy, but also surprised maybe that the patients followed this training program so vividly, and that they were happy with it. And in fact, in first instance, we planned to do a period of 3 months where one group didn't train and then trained, and then do a washout and a crossover study. But in fact, we couldn't make it because the patients liked the training so much and they didn't want to stop. So that's also a positive effect, because we concluded that they liked the program. But at least if you want to do it realistically, you should do it at least 2 times per week, and also do it in collaboration with a physical therapist who can supervise the program so that you do it in the right way. Of course, you can, if you can manage, you can adjust together with the physical therapist the intensity and the repetition and the type of equipment. And for example, I can imagine that not everybody is able to walk or to do or to cycle or whatsoever. So there are also options to do it in a different way. And here you have a rowing machine where you can use the cord to push and to stretch your arms, so you can train in that way also endurance, so with a rowing machine. So that's an alternative. Then you don't you don't need to use the apparatus. You can also use a band. And here, for example, is an example of a band that you can use to test your strength, to increase your strength. For example, here you see the hip abductors and the hip adductors with these type of bands that are available and that you can at least get in collaboration with your physical therapist. For the more severe patients, it might be useful to train the neck, and especially the neck is very weak in patients with Pompe's disease, and many patients have weak neck flexors, and so in this way you can train the neck. And also, if you only can use, for example, your lower arms, you can also use weights to try to train your arms. Now here are some examples. Also, for example, here at the bottom, if you have problems with flexing your foot, you can also use these type of steps to flex your foot. Also, the core balance exercises are, of course, quite complicated, and you need quite a lot of strength to do these tests, but you can also use a ball or other types of things to train your balance, and so in that way you can also train your core stability. So in conclusion, that's where I would like to leave it. And of course, the team, and in particular Linda and Marijn Favier, Linda van den Berg, Linda here in the front, as seen. And I don't know, I don't see Marijn so quickly, but it doesn't. No. Far left? Oh, here. Yeah, that she is. Okay. And of course, many people helped, and the departments, and the Spear Funds, that's the Muscles Fund in the Netherlands, who supported the study. Thank you very much. So no questions.
Well, you can have a minute for questions.
Okay.
How about one question? Let's have lunch. Oh, one question.
So I'll ask a question. You were mentioning the training effect, I think, and whether